I'm Trudie Lobban, founder of Arrhythmia Alliance, and this is the first of Living with SVT. We hope that many of your questions will be answered as you listen to our SVT pioneers. We are thrilled to welcome today the Arrhythmia Alliance SVT pioneer, Dr. Leon Ptaszek from Harvard Medical School and the Cardiac Arrhythmia Service at Massachusetts General Hospital. Thank you, Leon, for joining us.
I'm very happy to join you.
And I believe your first talk is going to be on what causes supraventricular tachycardia, SVT.
Our first session today will delve into the causes of supraventricular tachycardia. And this first session has just a few objectives, which are listed on the screen here. The first is the following. I was hoping that at the end of this session, you'll be better able to understand the electrical events that occur during normal heart rhythm. And by better understanding what happens under normal circumstances, I'm hoping that by the end of our session together today, you'll be able to better describe the different mechanisms responsible for supraventricular tachycardia. Normal rhythm of the heart is called normal sinus rhythm. And it's this sequence of electrical events that's responsible for the coordinated contraction of your heart's chambers, which is what allows blood to flow in an orderly fashion through your heart. This is a pictorial demonstration of the heart on the left side of the screen, in which you see a sliced open view of the heart from the front, where you see the two upper chambers of the heart, or the atria, and the two lower chambers of the heart, or the ventricles. The location of the heart's electrical system is highlighted here in yellow. And what happens during normal rhythm is the following. The first thing that happens is spontaneous electrical firing of your heart's metronome, or the SA node, which sits at the upper corner of your heart. This leads to nearly simultaneous contraction of your upper chambers of your heart, which inject blood into the lower chambers of the heart, or the ventricles. And this electrical firing of the upper chambers is what's seen as the P wave on an EKG. After this, there's a slight pause in the electrical activity in the heart, manifests as this little pause between the P wave and what comes next. Then the electrical signals flow through the bottom chambers of the heart, or the ventricles, leading to a much larger amplitude signal called the QRS complex. The amplitude is larger because the muscle mass of the bottom chambers is much greater. So it's this very carefully choreographed sequence of electrical events that allows for orderly contraction of the heart's chambers, as I mentioned. What happens when you have supraventricular tachycardia? Well, let's first by just investigating the term very briefly. Supraventricular just means above the ventricles, and tachycardia means fast heart rate, which means specifically a heart rate faster than 100 beats per minute. So why is it that people can end up with supraventricular tachycardia? Well, this is an umbrella term referring to any kind of fast heart rhythm that comes from the upper chambers of the heart. But I'd like to go through a few of the different potential mechanisms for supraventricular tachycardia with you now. Perhaps the most common reason for having supraventricular tachycardia is something called AV nodal reentrant tachycardia, which is alphabet soup, it seems, but it's a circuit that can form around the AV node, which is under ordinary circumstances, the only electrical connection between the upper and lower chambers of your heart. And in this tachycardia, you can have an electrical circuit that forms around the AV node, which goes very quickly and can lead to simultaneous firing of the upper and lower chambers of the heart. Another potential mechanism by which you can end up with the supraventricular tachycardia is AV reentrant tachycardia, or what many of you might have heard of before as being Wolff-Parkinson-White syndrome. And this is a consequence of having an extra electrical connection between the upper and lower chambers of the heart. As I mentioned earlier, under typical circumstances, the AV node is the only connection between the upper and lower chambers. If you have an accessory pathway, it means that the electrical signals can flow from the upper to the lower chambers of the heart through two pathways instead of just one. That also can happen with retrograde conduction as well. That is to say, signals from the bottom chambers of the heart can flow backwards to the upper chambers via this accessory pathway as well. And this can create the substrate for a fast heart rhythm, which I'm denoting here with these arrows, where you have conduction from the AV node to the ventricles, as you might have under ordinary circumstances, with retrograde conduction via this accessory pathway back to the atria. The signal wavefront then turns around the atria and goes back down the AV node again. And this also can go very fast, just like the AV node reentrant tachycardia can. One other mechanism for supraventricular tachycardia is an atrial tachycardia, or AT. And this is a fast rhythm that emanates from a focus within the upper chambers of the heart. And the remainder of the conduction system operates much as it would have under ordinary circumstances. It's just that it's being overdriven by this faster rhythm coming from the atria and this focus is outside of the sinoatrial node, which is where signals ordinarily come from. Now, many of you, I'm sure, are familiar with atrial fibrillation and atrial flutter. And even though these are heart rhythm issues that arise from the upper chambers of the heart, if you hear somebody talk about supraventricular tachycardia, chances are they're talking not about atrial fibrillation or flutter, but about AV-NRT, AV-RT, or AT, just for the sake of clarity. So what is it that leads to the supraventricular tachycardia? Well, like we talked about, in many cases, there's an abnormal anatomic substrate, like this accessory pathway or a focus of tissue in the atria that fires more rapidly than normal. And in addition to that underlying substrate, you can also have triggers in a person's day-to-day life that can bring on an episode of the fast heart rhythm. And these triggers are very individual, and they can include things like fatigue or lack of sleep, dehydration, emotionally stressful situations, non-cardiac illnesses or injuries like an infection, for example, or overuse of caffeine or other stimulants, and alcohol can be a trigger as well. And so these are the things that can bring out episodes of SVT in somebody who already has the anatomic substrate for it. So in summary, these are the things that I was hoping to discuss with you during this session. First is that normal sinus rhythm is the result of a very specific sequence of electrical events in the heart. And this is what leads to the orderly contraction of the heart's chambers and maintenance of a normal blood pressure. These events are, under ordinary circumstances, responsible for proper contraction of the heart's chambers. But in the context of supraventricular tachycardia, which is the result of abnormal electrical events in the upper chambers of the heart, you can have not only a fast heart rhythm, but a rhythm that leads to an abnormal sequence of contraction of the heart's chambers with respect to one another. For example, the example that I gave of the AV nodal reentrant tachycardia, in which the upper and the lower chambers of the heart beat simultaneously. Thank you very much for your attention.
Thank you, Leon. I think that explained it so well, really did. Just one question from me, really. We hear of heart attacks and we hear about, blocked blood vessels, etc. We very seldom hear about the electrics of the heart. Why is that, do you think?
Well, issues with the heart's electrical system can be the consequence of what people traditionally view as being heart disease, such as coronary artery disease or even valvular disease and heart failure. But it's not necessarily the case. People can have issues with the heart's electrical system, even in the context of an otherwise structurally normal heart. And as a consequence, these heart rhythm issues can impact people of all ages, not just the people who we traditionally think of when we're thinking about heart disease. In addition to that, I think some of my last talk here illustrated a few issues with terminology. That is to say, like I mentioned, supraventricular tachycardia is a blanket term referring to lots of different arrhythmias. And because of the complexities of the system, I think it's easy to get confused. And I think that because of that, there can be some confusion between what is heart disease due to coronary disease versus arrhythmias.
Thank you. Sam, do you have anything?
You mentioned the age. Do people's symptoms actually change with age?
It depends. It can be that over time, if somebody accumulates other medical problems, including even what we'll call traditional heart disease, coronary artery disease, heart failure, et cetera, that people are less able to tolerate supraventricular arrhythmias as they age.
That makes sense.
But it's not necessarily the case.
Okay.
And we have to ask about COVID-19. Can COVID-19 trigger symptoms? Are we more susceptible to COVID-19 if we have SVT?
Well, when it comes to all things pertaining to COVID-19, I would say we're learning as we go. What we have seen is that people who have COVID-19 can have an increased incidence of a number of different arrhythmias. And sometimes these arrhythmias can persist after the acute infection from COVID-19. The natural history of this is something that we're still trying to understand at this time.
Thank you. Sam, back to you.
With that, are you seeing any increase from the vaccinations, from the any reactions from the vaccinations on the SVT level?
I personally have not. No, I think anything that can lead to inflammation can lead to an aggravation of an underlying substrate for arrhythmia. And that pertains not just to supraventricular tachycardia, but also to any cardiac arrhythmia. Having said that, I cannot say that in my own practice that I've seen a large number of patients coming in with arrhythmias that were clearly triggered by a vaccine dose.
And one last question. When your heart's racing, you feel like it's panic, stress, anxiety. What can you do to try to stay calm during these episodes of SVT?
Well, I would say that's potentially easier said than done, but I think a few things can help. First is find a quiet place and try to sit down or even lie down. And if possible, try to even raise your legs above the level of your heart. There are a sequence of different maneuvers that are well described as being things that people can do to terminate episodes of tachycardia. That's the topic of one of my lectures as part of this session. So we can go into this in more depth in a little while. But I think finding a quiet place and sitting down, lying down are things that can certainly help.
Thank you. Well, as you said, let's go into your next presentation and learn some more about living with SVT.
So I'd like to continue our session by discussing some of the symptoms associated with supraventricular tachycardia. And the objectives of this session are the following. First is, I was hoping that after this session, you'll be better able to describe the diverse symptoms associated with supraventricular tachycardia. In addition, I was hoping that at the end of our session, you'd be able to better recognize SVT-related symptoms that raise concern and that may require immediate medical attention. Under normal circumstances, we have, as I mentioned earlier, very carefully choreographed electrical signals that lead to coordinated contraction of the heart's chambers. And I'm showing you a 12-lead EKG of normal sinus rhythm here. And as you can see going across the tracing here, these deflections are very evenly spaced, indicating a heart rhythm that's fairly constant. However, during the course of our daily lives, our heart rates do not remain constant. Rather, they increase and decrease based on what we're doing at the time. And this is a consequence of many factors, including the very extensive connections between the brain and the heart. And in general, increased activity levels are associated with an increase in heart rate, and decreased activity levels or even sleep are associated with a decrease in heart rate. And in the course of a regular day, you'll see almost continuous variation in your heart rates. And this is a tracing of someone's heart rate taken throughout the course of a day. You see the timestamps here, 6 a.m., noon, 6 p.m., and so forth. And you see the heart rate listed on the left side here. And you see that throughout the day, heart rates vary almost continuously with relatively smooth transitions from one rate to the next. And this highlights a key principle, and that is exercise will typically lead to a smooth change in heart rates. That is to say, with activation, your brain will send signals to your heart, leading to a gradual and progressive increase in heart rates. Now, sometimes the rate of change is more sudden than at other times, but what you're looking for is a curve like I'm showing you here in this tracing associated with exercise. So here's someone who woke up at 6 a.m. Or just before, heart rate's gradually increasing, then around 7 o'clock, went for some exercise, and then relaxed afterward with gradual reduction in heart rates. And this is very distinct from the changes in heart rates you'll see with supraventricular tachycardia. Now, if someone has an episode of supraventricular tachycardia, you'll see a sudden change in heart rates as described in this heart rate tracing on the right. Here you see somebody who's seemingly sleeping before 6 a.m., then waking up with some of these jagged variations in their heart rates associated with ordinary activities. And then somewhere around 11 a.m., there's a sudden increase in heart rate, and the person remains at this faster heart rate fairly consistently for several hours in a manner that's not really consistent with what you would see with exercise. And this type of step function for the engineers out there is what you'd be more likely to see in the way of heart rate variation as a consequence of supraventricular tachycardia, as distinct from ordinary heart rate variations in normal sinus rhythm. And this highlights a key feature of SVT-related symptoms. That is to say, when there's an episode of supraventricular tachycardia, you'll see a sudden change in the heart rate. So here on this tracing, we're seeing normal sinus rhythm going across, and then there's a very brief burst of supraventricular tachycardia with resumption, sudden resumption of sinus rhythm afterwards. And although this is a very short burst of the fast heart rhythm, this highlights this principle that we're talking about, this sudden change in heart rate. And many people who have episodes of supraventricular tachycardia will indicate that their episodes are characterized by sudden onset of a rapid and regular heart rate and sudden disappearance of the fast heart rhythm and resumption of the normal heart rhythm. While they're in supraventricular tachycardia, people report a very wide array of symptoms. These include not just that rapid and regular heartbeat that I was telling you about. Sometimes people will feel like they're anxious. And one of my teachers, while I was training, told me that the symptoms associated with anxiety can be indistinguishable from the symptoms associated with a fast heart rhythm. And it may take some doing to figure out which is contributing to a particular person's symptoms, because anxiety and SVT are both common phenomena, and it's possible that both can be present in the same person. In addition to rapid heartbeat and symptoms consistent with anxiety episodes, you can also experience chest discomfort or shortness of breath in the context of supraventricular tachycardia. And some people will even describe pulsation in the neck. Now, this is something that you may hear about classically in the context of the AV nodal reentrant tachycardia that I described to you in our last session, the tachycardia that's driven by a circuit around the AV node, which is, as you remember, the electrical connection between the upper and lower chambers of the heart. And because of where that circuit sits, it leads to simultaneous contraction of the upper and lower chambers of the heart, as we're seeing once again in this diagram. And when the upper and lower chambers beat at the same time, you have not just a faster heart rate, but again, as I mentioned earlier, an abnormal sequence of events. So what happens is the upper chambers, when they contract, instead of contracting into a ventricle that's ready to accept the blood, because the ventricles are contracting at the same time, this valve between the upper and lower chambers of the heart is closed. As a consequence, the blood in the atria can flow backwards, and in this case, flow upwards toward your neck, leading to a feeling of fullness in the neck. So it's not just a faster heart rhythm, it's an abnormal sequence of events that can lead to the symptoms. Now, what are the kinds of symptoms you need to be concerned about? Well, the most concerning symptoms include lightheadedness or feeling faint, or loss of consciousness or near loss of consciousness. These concern us because these are signs that your blood pressure is dropping in the context of the arrhythmia. And any sudden drop in blood pressure caused by a heart rhythm issue is an indication that you need prompt medical attention. So just to summarize, supraventricular tachycardias can be associated with a diverse array of symptoms. And the most ominous symptoms that you need to keep in mind include loss of consciousness or near loss of consciousness, as these are indicators that your body's unable to maintain a normal blood pressure in the context of the arrhythmia. Thank you for your attention.
Thank you. Can I just ask, Sam was going to go first, but can I just ask one question? So, Leon, you mentioned about, seeking prompt medical attention if lightheaded, loss of consciousness, if you have SVT. But what about if you don't know if you have SVT? Do you, often anybody, we always say there's no such thing as a simple faint. It should always be investigated. So are you saying they should call 911, they should go off to ER? Could you define prompt attention, please?
Of course. I think that anybody who nearly loses consciousness or actually loses consciousness should be evaluated promptly. And I think that under ordinary circumstances means going to the emergency department. Because even if you have an established physician, and even if they're able to see you in the office, it may not be possible for them to do the full workup of your symptoms and do all the necessary diagnostic tests in the context of an outpatient visit. So I think whether you have an established relationship with a cardiologist or not, and even if you speak with that cardiologist, it's likely to be most appropriate that you go right to an emergency room to be evaluated.
Thank you. Sam.
Just going to go off that question too, because are there you mentioned the fainting, but are there other arrhythmias or other conditions that might mimic the same sort of low blood pressure drop, the fainting, and then also have the flutter of the heart that would kind of mimic the same, that might not be SVT?
Yeah, the answer is absolutely yes. And I think that's why I agree wholeheartedly with Trudie's comment that there's no simple faint. Now, this is something we'll be getting into in subsequent sessions, but supraventricular tachycardias under most circumstances are not life-threatening. However, the symptoms associated with SVT can mimic the symptoms associated with a ventricular tachycardia, which is more dangerous and could be immediately life-threatening. And because there's no way of being able to differentiate the two based on symptoms alone, the only way to complete the workup and the differentiation between the two is to be seen in person by a clinician, typically in an emergency room setting.
Absolutely. That's what I was thinking, Leon, the moment you mentioned about loss of consciousness and no such thing as a simple faint. So what causes SVT to suddenly develop in a person when they've not had any problems previously?
So the answer to that question is very complicated. It can have to do with the circumstances in that person's life. For example, it could be that the person had an illness, was dehydrated, was losing sleep, had some emotional distress, et cetera, that could have brought up episodes. The ordinary history of supraventricular tachycardias is the following. Under most circumstances, people typically, if they have a predisposition for a supraventricular tachycardia, they start happening in adolescence or in a person's, third decade of life. And sometimes they'll level out and sometimes they'll even go away. And then there's a second peak, if you will, of people who start having supraventricular tachycardias in middle age. So there is this time-dependent sequence. We don't understand all the factors responsible for that, but even for those people who have the substrate for it, it's important to keep in mind that there are other circumstances in a person's life that may bring out episodes of SVT in a given time.
So one of our viewers submitted a question asking whether it was hereditary because she has SVT and her son in adolescence has developed SVT. Is that coincidence or is it hereditary?
Our understanding of the genetics of SVT is growing every month. And at this point, it's not always the case that we can point to a specific hereditary cause in most people with SVT, but there is some data suggesting that in many people, there is a hereditary connection. Having said that, it may not necessarily change the way we treat SVT in an individual person. The workup would proceed as it would have.
And another question from one of our viewers, are there any lifestyle changes that can help prevent episodes?
It's a really good question, and I think the answer will depend on the person. So I think these individual triggers, whether it's dehydration, fatigue, emotional distress, or other factors, these are things that people will often identify on their own as being their individual set of triggers. And so I think if a person identifies what the triggers are for their episodes, they can work towards addressing them, knowing full well that one person's triggers may be completely different from another's. So I don't think that there's one set of triggers for us to focus on here. I think it's really just up to the individual to look into what they think is associated with their events and try to address it if possible.
Thank you. Sam, I think you've got a question about exercise that we've had submitted.
Yes. So speaking of lifestyle, is it safe to exercise with SVT?
So people with SVT can exercise, that's for sure. But I think if you have SVT, it's important to be evaluated by a physician to make sure that your heart is indeed structurally normal and make sure that you don't have a variant of SVT that may lead to higher risk with exercise. And by that, I mean the following. Sometimes people with Wolff-Parkinson-White syndrome should avoid competitive athletics and other sort of high strain physical activity. They represent just a percentage of all people with supraventricular tachycardia, but it's important to keep in mind that you should be evaluated so that you can figure out if you are or are not one of those people who needs to avoid exercise. But most people still can in general. Now, you should also keep in mind that it's one thing to have a history of supraventricular tachycardia and be able to exercise. It's another thing to continue exercising if you're in the midst of an episode of supraventricular tachycardia, right? I think that's something distinct, and I think it's worth clarifying. If you're having an episode of supraventricular tachycardia, I think you're best served to let the episode finish, right? And seek treatment if appropriate, and then go back to exercise when it's appropriate to do so and when you're in normal rhythm.
So if you develop SVT while you're working out or you have an episode of SVT, you should cease your workout and wait for it to subside before.
That's my typical advice to my patients, yes.
Is there a type of exercise you would recommend that's more low impact and for if you've not had the full workup but do know have SVT?
I would say that it's most important to just go through the steps in order. Do the workup first,
okay,
and then proceed only when you know that it's safe and appropriate for you to exercise. I think in general, low impact exercise, light to moderate exercise should be safe. But again, only once you've gone through a proper workup. Again, getting back to our earlier point about the fact that there's an overlap of symptoms associated with supraventricular tachycardias as well as ventricular tachycardias, right? And I think there are a lot of people who may think they have an SVT when in fact it's not, right? And I've seen this a lot lately where someone will have symptoms and they'll wear an Apple Watch and they think that they've been able to diagnose the arrhythmia for themselves and they just keep on going when in fact they didn't arrive at the right conclusion and it wasn't necessarily safe for them to continue. So I think if there's any doubt in your mind, reach out to your clinician.
So most people know about heart doctors, cardiologists, but a lot of people don't know that there are subspecialties within cardiology, one of them being an electrophysiologist, a cardiologist who specializes in heart rhythm disorders. So should people with SVT ask to be referred on to an electrophysiologist?
I think that's something that the person's cardiologist can discuss with the patient. I think under most circumstances, yes, it's appropriate to be evaluated by a cardiac electrophysiologist because they'll be best able to discuss with the patient what treatment options are available and how to best live with the arrhythmia.
Thank you, and that's perfect to lead on to your next session, treatments.
Excellent. So I'd like to continue our conversation with a brief discussion of treatment options for supraventricular tachycardia. And my objectives for this session are the following. At the end of this session, I was hoping that you would be better able to describe the treatments that are available to you for management of supraventricular tachycardia. And I also hope that you'd be better able to understand the factors that lead to the selection of specific treatments. In general, supraventricular tachycardia is not typically life-threatening. However, as we've highlighted during our session thus far, it can be difficult to distinguish between supraventricular tachycardia and other types of cardiac arrhythmias that can be life-threatening. Therefore, I think any type of fast heart rhythm associated with symptoms should be evaluated by a cardiologist promptly. And in general, for people in whom supraventricular tachycardia has been identified properly as being the cause of a person's symptoms, it's typically the case that the aggressiveness of the treatment measures that we use is proportional to the severity of symptoms. And as part of our description of severity, I think it's important to keep in mind that there are a few factors contributing, including the frequency of the episodes, the duration of the episodes, and the intensity of the associated symptoms. There are three general types of interventions available for management of supraventricular tachycardias. These include physical maneuvers that can be undertaken by the patient individually, medications, which can be taken either on an as-needed basis for treatment of individual episodes or on a daily basis. And last is interventional procedures, minimally invasive procedures that can be performed to address the physical substrate in the heart that's responsible for the arrhythmia. And as I've highlighted already, the selection of the individual treatment strategy will be based on the patient's individual circumstances, notably the specific mechanism of their arrhythmia, as well as the intensity of the associated symptoms. Let's start with maneuvers. There have been several maneuvers that have been shown to stop individual episodes of SVT. These include some of the maneuvers that I mentioned a little bit earlier in our session, including bearing down or squatting, or splashing cold water on the face or neck, or even drinking cold water, massage of the carotid artery or the blood vessels in your neck, or lying flat on your back, and even raising your legs above the level of the heart. All of these maneuvers have been described as being things that can terminate episodes of supraventricular tachycardia. The pros of these maneuvers include the fact that they're non-invasive and can be, generally speaking, self-administered in a safe fashion by the patient. The cons include that these maneuvers only work for single episodes and do nothing to change the physical substrate in the heart that's responsible for the arrhythmia. And it's possible that these maneuvers are not effective, and sometimes they work for people in some episodes and not others, or sometimes they work for a patient for a given period of time and then they stop working. Let's move on to medications. Now, there are several medications that are known to have the capability to terminate episodes of supraventricular tachycardia. The most commonly used oral medications include beta blockers and calcium channel blockers, although more potent antiarrhythmic drugs, such as flecainide, for example, can also be used for treatment of supraventricular tachycardias. And there are several techniques for use of these medications, one being what's called a pill-in-pocket technique, where a person can take a dose of the medication only when they're in the midst of an episode of tachycardia. And this is typically most appropriate for those people who are having relatively infrequent episodes. Or if the person's having very frequent episodes, say an episode every week or two or something like that, then we can move on to daily therapy with these medications. There are also intravenous medications that can terminate episodes of supraventricular tachycardia, including IV forms of beta blockers and calcium channel blockers. There is one distinct medication that can be used to terminate an episode of supraventricular tachycardia. This is called adenosine. All IV medications need to be administered by a healthcare professional in a supervised setting. So these are not things that patients can typically use on their own, the way they might have used a pill-in-pocket approach, for example. There are several advantages to the use of medications, including the fact that they're non-invasive and that they're generally safe and well tolerated. The cons include the fact that these medications do nothing to change the underlying physical substrate in your heart that's responsible for propagating the arrhythmia. And they're not always effective. And sometimes patients will find that a given medication approach will work for some period of time and then will stop working. And then there's also the possibility that some people simply will not tolerate these medications due to side effects and other issues. The last category of treatment options that I wanted to cover with you during this session is an interventional procedure or an ablation. This is a minimally invasive procedure that is performed in a hospital setting. It involves insertion of sheaths in your veins and sometimes even your arteries. And it's typically done under conscious sedation, what we like to call a twilight sleep. And during the procedure, these sheaths, which are very similar to intravenous sheaths, just with a larger bore lumen or larger bore straw, if you will. These are used as conduits for catheters, which are advanced through your vascular system into your heart. And these catheters are then used to measure the electrical activity of your heart and to identify the area within your heart that's responsible for your particular arrhythmia. And then a specially equipped roving catheter can then be used to electrically silence this area that's responsible for propagating your arrhythmia. And the silencing technique involves delivery of either heat or cooling to that site. This is an X-ray picture of a person's heart. You can see the heart borders here in the middle of the screen, surrounded by the lung on this side, and we don't really quite see the lung on that side, but you do see the spine here. And within the borders of the heart, which are mirrored in this pictorial demonstration of the heart that we've been looking at in our sessions thus far, you see the right atrium with a catheter within it. You also see a catheter here, which is within the coronary sinus, which is a vein that courses between the left atrium and the left ventricle. You see a catheter that's out in the tip of the right ventricle here. It's this one. And then you see this catheter here, which sits at the crux of the heart, very close to the AV node and the bundle of His, which is, as I've described earlier during our session, under typical circumstances, the only electrical connection between the upper and lower chambers of the heart. And I include this just so you have a sense of what catheters are placed and how they're placed within the heart. And during this procedure, it's possible for us to use roving catheters, which are specially equipped to create a virtual three-dimensional map of the inside of the chambers of your heart. So this is a map of the right atrium and the left atrium. And you see here a depiction, virtual depiction of that coronary sinus catheter, which you see here in the X-ray view. And here you see a virtual depiction of the ablation catheter, which is not shown in this X-ray view here. And the ablation catheter is sitting on top of an area where the arrhythmia was identified, and that's shown by these white dots. and a sequence of ablation lesions or delivery of radio frequency energy, which heated the tissue to electrically inactivate it in the neighborhood of the physical area of the heart that was shown to be responsible for propagating this particular person's arrhythmia. And after delivery of these radio frequency heating lesions, the arrhythmia was silenced and could not be reinduced. And this very busy slide was included for one reason, and that is to show you what had happened for this particular patient who was in an arrhythmia called an atrial tachycardia, which is present on the left-hand side of the screen here, which includes surface EKG leads at the top, as well as the electrical tracings measured by the various different catheters that I showed you in the prior slides. So the person is in this fast heart rhythm. The ablation was started here, and a few seconds later, normal rhythm was restored. And this is a consequence of the fact that during the ablation, the physical substrate that was responsible for the arrhythmia was modified, making it impossible for the arrhythmia to propagate. And so the pros of the invasive interventional procedure or the ablation is that you can electrically inactivate the substrate responsible for the arrhythmia, and depending upon the arrhythmia and depending upon the person, is potentially curative. And these procedures are generally safe and well tolerated. Now, the cons are that at the end of the day, even if it's a safe procedure, it's still an invasive procedure, and bad things can happen, and there are associated risks with the procedure. And in some cases, the procedure is not curative. So in summary, I think there are three broad categories of interventions that are available for supraventricular tachycardias that I want you to be aware of. These include the maneuvers like bearing down, splashing water on the face, etc. Medications, including the pill and pocket medications or even daily medications, or even additional medications that could be administered either orally or by vein in a hospital setting. And last is the interventional procedures or the ablations that can be performed to alter the substrate that's responsible for your arrhythmia. Each type of intervention has a distinct set of advantages and disadvantages, and the patient's individual needs will ultimately determine the appropriate intervention in their case. Thanks again for your attention.
Thank you again for an excellent presentation, and I know we have lots of questions for you regarding the treatments. So I will start. You mentioned at the beginning about frequency and intensity of SVT. One person's frequency or intensity may be different than someone else. So how would you define these two?
So I think this is something that we define in conjunction with our patients. At the end of the day, a person will determine for themselves how much of an arrhythmia they can tolerate. For example, someone may have relatively infrequent episodes of an arrhythmia, but if they're particularly intense, and if these episodes make it impossible for them to live up to their responsibilities, say you have a parent of young children who simply cannot have an episode of tachycardia that's unpredictable in nature while they're trying to look after their children, this is somebody in whom you may decide to intervene sooner than another person who finds that they're not as limited by their episodes, or finds that they have an easier time in just working with the episodes and terminating them. And it's often the case that the relative success of these maneuvers or pill and pocket strategies will determine whether or not a more aggressive intervention will be needed.
And you mentioned about some medications have side effects. What sort of side effects?
There are many different side effects, including fatigue and decrease in blood pressure, which can lead to some lightheadedness. And it's often the case that people who are young and otherwise healthy have a hard time living with these medications, which can drop the blood pressure.
Sam, I think you had a question on the medication, didn't you?
I did. If someone isn't otherwise healthy and has other conditions that they're on medications for, could that alter the treatment options for SVT?
It may, and I think this relates to a question that you asked earlier regarding how an SVT presentation can change in an individual person over the course of their lifespan. Now, if a person accumulates a number of medical conditions and is on other medications, it may become the case, not necessarily, but it may become the case that they're less able to tolerate these episodes, such that we're more aggressive about offering perhaps even an interventional option for such patients. But again, there's a great degree of variability in how these things present. In general, we will seek more aggressive treatments for people who are profoundly affected by their supraventricular tachycardias or have other warning signs, such as near loss of consciousness or loss of consciousness associated with an SVT event.
Now, I have a lot of questions about ablation, but I know you have another presentation, so I think we ought to listen to your presentation because I'm sure you'll answer a lot of these questions.
Fair enough. For our last session, I would like to discuss with you the circumstances under which catheter ablation is warranted for treatment of supraventricular tachycardia. I have just one objective in this session, and that is at the end of this session, I am hopeful that you'll be better able to understand the circumstances that warrant catheter ablation for SVT. As I mentioned in our last session, the strategy that we use to treat SVT will be determined in large part by the burden of symptoms associated with the arrhythmia, ranging from infrequent and brief episodes to frequent episodes that are long in duration. Knowing full well that under all circumstances, the aggressiveness of our treatment strategy will be proportional to the severity of a person's symptoms. So for those patients who have infrequent and brief triggers, we can start by offering relatively minimal treatment strategies, including addressing triggers, if any have been identified, whether they be dehydration, stress, fatigue, other illness, etc. Use of physical maneuvers like bearing down, splashing water in the face, etc., or perhaps even a pill-in-pocket medication. Or in some cases, a combination between pill-in-pocket medication and maneuvers. For those patients who have very frequent or long episodes, it may no longer be appropriate or convenient for a patient to try to use maneuvers or pill-in-pocket medication, and instead, we may move toward daily medical therapy as prophylaxis. And for those people who have episodes of supraventricular tachycardia despite use of daily medical therapy, or people who, for whatever reason, simply cannot tolerate the medications, we can then move forward for an ablation strategy. And under general circumstances, we'll typically proceed with an ablation under the following circumstance. First and foremost, for somebody with severe and limiting symptoms, or for somebody in whom the medications or maneuvers are ineffective, or if the medications are associated with intolerable side effects, like we mentioned. And one other circumstance under which we would move forward with an ablation is somebody who has an identified Wolff-Parkinson-White syndrome with high-risk features. And in order to highlight how we can go about this decision-making process, which is always individualized to the patient, I'd like to go through a few different case presentations with you. I'll start with the description of a 47-year-old man who's experienced intermittent palpitations since he was 16 years old. And he tells us that his episodes are characterized by a sudden onset of a rapid, regular heart rhythm that appears and disappears spontaneously and suddenly. He's able to avoid episodes in general by getting enough sleep and by remaining hydrated. And he tells us that his longest episode lasted 30 minutes. He's used the bearing down maneuver a handful of times in his life, in those circumstances where the episodes were not stopping on their own, and he found that it was effective each time. So the question I have for the group is, what's the best approach to treating this patient? A, no further treatment at this time, just continue maneuvers as needed. B, proceed with pill and pocket medication. C, start a daily medical regimen. Or D, proceed with ablation. In this case, we selected to proceed with no further treatment at that time, as the patient found that his episodes of supraventricular tachycardia were not associated with severe and limiting symptoms, meaning he never got to a point where he felt that he was either close to passing out or actually passing out. He never felt that he was in any danger, either in recreation or at work. And he found that the episode occurred so infrequently that he was not willing to move ahead with any medications or anything more aggressive. Next case involves a 24-year-old woman who's experienced 3 episodes of palpitations over the course of a single year. Prior to that, she had never had any awareness of her heart rhythm and had no issues related to her heart. On each of these 3 occasions of tachycardia, she was extremely symptomatic, getting very lightheaded, almost passing out, and called 911 in each circumstance and was taken by EMS to her local hospital in each case. And there she was evaluated by clinicians who identified her arrhythmia as a supraventricular tachycardia. And in each case, treatment with beta blockers or other medications was ineffective. So she underwent administration of adenosine intravenously, which terminated the supraventricular tachycardia. After her most recent event, she was getting very concerned and very nervous about the frequency and intensity of her episodes, so she was started on a daily beta blocker by her cardiologist. While on the beta blocker, leading up to the appointment during which we're discussing these options, she's not experienced any additional episodes of supraventricular tachycardia. And that's great. But the downside is that she's having a really hard time keeping up with her graduate studies because of the medication. So she's having a hard time concentrating. She's ending up having a lot of fatigue on the beta blocker. So she's wondering what other options are available to her. So in this case, what do you think the best approach to treating this patient would be? Number 1, just stop the beta blocker due to side effects. B, no further treatment, just continue the beta blocker and try to get used to the side effects. C, administer an additional pill and pocket beta blocker if she has a recurrence of the arrhythmia, even if she's taking the daily beta blocker. Or D, proceed to ablation. And in this case, after a detailed discussion of all these options, the patient and the clinician opted to proceed with the ablation, but know that this decision was the result of shared decision-making after consideration of all these possible options. And this is just an electrogram taken of the patient in her fast heart rhythm. And during her EP study, it was found that she had an AV nodal reentrant tachycardia. And on this slide, I'm including that same simplified pictogram of the heart showing the upper and lower chambers of the heart. And this is that 3D virtual shell of the crux of the heart, where these yellow dots here represent the location of this His bundle, or the electrical connection between the upper and lower chambers of the heart. This white dot represents the ostium of the coronary sinus, which is that vein that courses between your left atrium and your left ventricle, which sits just underneath His bundle here. And this person was found to have an AV nodal reentrant tachycardia, and we were able to successfully terminate her arrhythmia by ablating in the area depicted by these little red dots, which are just below the AV node here, or what's called the compact AV node. And during her ablation, we found that after administration of these radiofrequency lesions, we were unable to reinduce her arrhythmia, and she's had no subsequent arrhythmia since. She's not been taking her beta blocker and doing just fine in school. So in summary, I would say the following. First is that the aggressiveness of the treatment strategy we take to address somebody's supraventricular tachycardia will be proportional to the impact of the arrhythmia, either in terms of symptoms or in terms of patient safety. In general, for patients with infrequent arrhythmia episodes, we can start with consideration for minimal interventions such as these physical maneuvers or pill and pocket medications. For people with frequent arrhythmia episodes, we can proceed to daily medications or even consider an ablation. Knowing full well that there may be specific circumstances, for example, people with the Wolff-Parkinson-White syndrome, for example, in which we need to think about proceeding with an ablation, even in the midst of symptoms that may be considered by the patient to be fairly minimal. Ablation is indicated for those patients in whom minimal interventions like medications or the maneuvers are ineffective. And we can also consider an ablation for somebody in whom long-term medical therapy is not preferred. And that is the end of this session. Thanks again for your attention.
Thank you so much, Leon. And again, I think it's going to answer lots of questions. But I do have a few. So you've explained fantastically who, what, why should possibly have an ablation. But some general questions. How long am I likely to be in hospital if I go in for an ablation?
So the answer to that question will differ between different hospital centers around the world. I can tell you the way we practice locally here in Boston is that most people who undergo an ablation will spend one night in the hospital and will typically go home by midday the following day.
And how long does the procedure actually take normally on average?
It's a very good question. That can be quite variable. On the shorter end, these procedures can take 2 hours, but sometimes they can take 4 or 5 hours or even longer, depending upon the mechanism of the arrhythmia and how difficult it is to identify the region of the heart that's responsible and how difficult it is to successfully deliver ablation lesions to that area of the heart.
Will the person be awake during this, or do they receive a general anesthetic?
It's a good question. Again, the approach will be tailored to the patient. Under most circumstances, patients will receive what's called conscious sedation, or what I'll call twilight sleep, in which most people will snooze through the procedure, or at least most of it, but can still be awoken. For those patients who simply cannot tolerate the procedure, it is an option to proceed under general anesthesia, and some ablation procedures are indeed performed that way. Sometimes during certain parts of the procedure, we vary the amount or the depth of sedation delivered, because it's important to note that for those patients with supraventricular tachycardias, if we sedate the patient too much, it's possible that as the patient goes to sleep, so will the arrhythmia. And we don't want to put the patient through the procedure without maximizing the likelihood of success for the patient.
Now, a lot of people think any operation on the heart is open heart surgery, major surgery. Can you explain, when you put the catheter, when you put the wire in, where that actually enters the body?
Sure, of course. So these are intravenous sheaths, an IV like you might have in your arm, just with the larger bore of the straw, if you will. We can enter through several different areas, although the most frequent veins used for these procedures are the femoral veins, which are the veins between your hip bones and your pubic bone.
So it's not open heart surgery. They're not going to have a big scar afterwards.
No, in all the procedures of this type that I've seen performed, I've yet to see a patient in whom there was a scar visible from the entry point of one of these sheaths. These are little skin nicks that are made next to the IV. They're only a few millimeters long and heal without a scar.
It is incredible, but of course, for people that don't know, it's frightening, and they think they're going to have major heart surgery. So,
Well, having said that, even though it's a minimally invasive procedure, those of us who do these procedures always take each procedure very seriously every time.
how soon will they be able to return to work?
We typically ask patients to avoid strenuous physical activity for up to a week after the procedure, primarily to let those groin access sites heal up. And then after that, it's really just a matter of how the patient is feeling.
And what about driving? How soon can they drive?
It depends on the circumstances that led to the ablation. Those people who have had episodes of loss of consciousness may have to wait before they return to driving, depending upon how everything works out for them. That's one thing to keep in mind. But presuming that there is no episode of loss of consciousness, it's often the case that people can go back to driving very shortly after the procedure. Although, even though driving is not what I would consider strenuous physical exercise, it does place strain on the segment of the femoral vein that was accessed for the procedure. So I think it's sensible to stay away from driving for approximately a week after the procedure.
Is there anything else they should or shouldn't do following the procedure?
I think giving their body a chance to heal for at least a week and perhaps even two is most appropriate.
And what is the success rate of for ablation for SVT? I know that varies from person to person, but generally.
So in general, the answer to that question depends on the mechanism of the arrhythmia. So these ablations can be curative, meaning greater than 90 to 95% success rate for patients with Wolff-Parkinson-White syndrome or with AV nodal reentrant tachycardia. These are arrhythmias that can just go away after the ablation. For atrial tachycardias, the success rate is lower, sometimes quoted as being as low as 60%, but so considerably more variable than it is for AV NRTs and AVRTs.
So if the ablation isn't successful, do they then go back onto medication, or is it possible to have more than one ablation?
It is possible to need more than one ablation, but again, it's really the need for an ablation is often a reflection of what the original mechanism of the arrhythmia was. Under some circumstances, it may be deemed unsafe to proceed with an ablation for a given person's circumstances, in which case additional medications are needed. But one of the goals of proceeding with an ablation is to treat the arrhythmia without requiring medication. So we are typically going into this procedure with the goal of having the patients on no additional cardiac medications long term.
So for many people that have ablation for SVT, they can hopefully rest for a week or so afterwards and then carry on living their life without SVT.
That's correct. That is our goal.
What a wonderful way to end this session, living with SVT, or maybe we should have named it living without SVT after successful treatment. Dr. Leon Ptaszek, thank you so much for your time and for explaining everything from what causes SVT to the treatment options and living beyond after SVT. Thank you so much.
Well, thank you very much for inviting me. It was a great pleasure to join you today.
Thank you.